Well, Tim, can you explain to us a little bit about why the program that you're working on is different from what's currently out there?
Sure. So, I mean, I think a lot of people are trying to identify patients, in time. There's quite a lot of work in that field. What is different, I think, about what we're doing is we're recognizing the value of all the data that's already sitting there. So this isn't reactive to an individual blood test that's come in. We're not waiting for a referral. We're saying there's a huge amount of data sitting in our systems, and all we need to do is interrogate that in the right way, and we can risk stratify our population. And I think the risk stratification bit is really important because, as you said earlier, we can't have everybody coming to a liver clinic. It doesn't work like that. So we need to target our resources as well at the right people. And our clinical systems, probably universally, probably worldwide, if you know who the patient is, you can get a lot of data about them. So I can key your details in and I can pull up your bloods, your x-ray, everything there. But what we can't do at the moment very easily is say, okay, show me all the patients with this particular pattern, or all the patients who meet that risk threshold, who are starting to show perhaps signs of advanced liver disease, whatever it is you're looking for. And so literally our approach is different. We're taking that huge stack of data, curating it in a different way, and just priming it for those questions. And at the moment, we're priming it for liver disease specific and chronic liver disease specific questions. But you can, I think you said right at the beginning, we could apply this kind of approach to all sorts of things and go and find people who need prevention or early treatment much earlier on, and not wait for them to be picked up. And I think also the history of screening programs, it's checkered in liver world. Obviously, cardiovascular screening, cancer screening, it's much more embedded, but we've just not got traction with screening, I think, in the vast majority of what we're doing in the liver world. And I don't, again, what it's like in North America. Specifically, we screen high-risk populations for hepatitis B, hepatitis C, and so on, but that's pretty much where it ends. So if we're not going to have a screening program and we've got this massive stack of data, let's go and interrogate it and find what we can and risk stratify our population.
Mark, this is actually, sorry, I don't want to interrupt you, but it's funny because as Tim talks, I'm thinking about you and how many times you've told me that you don't use the word screening, use case finding. And really, this program is about case finding specifically, right?
And a big, and which is exactly, I think, what Tim was just describing. It's the problem when you, because of this checkered history of screening, but also because there's so many people that want their screening programs for their disease, that it becomes an overwhelming thing, and it's mandated. A screening program, by definition, becomes mandated, at least in Canada. And so, say for breast cancer screening or whatever, then there's a ritualistic thing you go through, which is very expensive and it's very time consuming for family physicians and all the structures that have to be built around it. And so there's not a lot of receptivity, certainly in Canada, for primary care about screening programs. Case finding, they're quite interested in, because the way when I'm talking to primary care, it's really about empowering that primary care physician to care better for their groups of patients that they have under their care. And so when you have a certain thing, and say with Tim, through an EMR where you can flag someone as being at risk, most family doctors are really like having that done, because they're very busy. They don't have time to sort of look through all this data. Suddenly a flag comes up and says, have you thought about screening this person for non-alcoholic fatty liver disease or whatever disease? It makes a huge difference. And so I think you can do these kinds of things. Of course, in Calgary, we do it's a little bit different, but it just because we have multiple primary care providers with different EMR systems. And so you'd have to do it for each one of those becomes a bit more challenging. And so we just need to wait until they're more integrated. And they're all becoming integrated over time, because the bigger companies are buying the smaller companies. And so I think hopefully we'll get more like the NHS at some point, where we can really implement these across a universal system, like an Epic type system that's everywhere, where people can then we can use the same algorithm or the same IT support, I guess, to make sure that that's in that EMR and doing what it's supposed to do.
Thanks, Mark. Tim, so you came up, I don't know if it was you who came up, but maybe you can even tell us how you came up with the name. So hepatocyte, SIGHT, is kind of a cool name to, when you're talking about finding cases of advanced liver disease. So how is that program going? Like how many patients have been enrolled, or how many clinics, or just to get an idea of the size of that program would be kind of good to know.
So where we're at the moment, we doing this within our local population in Somerset. So that's a kind of integrated care system for 500,000 people. Interestingly, although that's not a completely stable population, some people have moved away. We've got around about 500,000 people in our database, which suggests that most people, there'll be some people who've never had a blood test in the last 15, 20 years, but most of the adult population have had a blood test at some point, and they're in the system. So that's the size of the data set we're looking at. We build a system in terms of calling patients with clear markers of chronic liver disease. This is a very early stage. So we've literally sent out about 20 requests to people to come to clinic. And this is just trying the process at the moment for us. So we're learning as we go, trying the process, come and see us. We found that you might be at risk of one or other chronic liver disease conditions. And we're very cautious. Where does that go in terms of scale? I think we'd probably all recognize several hundreds of patients out there who are probably at high risk. And we can use our system to find those now. But we're just not primed, ready to have a few extra 100 patients coming to clinic right now. So we're working on that part of the program. But that's the order of magnitude. And we want to find high-risk fatty liver disease, but also other chronic liver disease in there as well.
Well, I mean, to be clear, it's in the early stages, but 20 people who wouldn't have known that they had advanced liver disease, you could very well have saved their life, right? So, and those, I mean, people say even one patient's life matters, right? So, you get to 20, and then this is a start. And if it's something that works really well, then it'll be a lot more of this happening. What did the patients that you talked to actually say, like in general?
So today, the ones that have come to clinic, universally positive. They really have been. We were nervous to an extent. I think the healthcare organizations were a little bit nervous because, is this about misdiagnosis in some way? And my feeling isn't about misdiagnosis. This is about just being more proactive in making a diagnosis. We know that minor abnormalities are not acted on, so we're being much more proactive. The patient's response to this, when we first spoke to patients before we did this, there was a little bit of kind of questioning. You mean you're not doing this double checking already? Surely that's what you guys do. You check through our blood test, retrospectively. Well, we don't. And a lot of that is around data. So access to data is a huge problem sometimes with these kind of projects and programs. Patients, when they come to us now, have all said, once I've explained why they're in clinic, they haven't been referred, they don't know why they're there. Once I've explained that, they've all said, well, thank you for doing this. Thank you for doing this work. What does it mean for me? And that bit about how do I need to be more healthy comes out almost from them rather than from the physician in the clinic. That's really very different experience in clinic, in my opinion. We haven't had pushback as yet. We haven't had people saying, what on earth are you doing? Scouring around through all this data and looking at my records of my past stuff. That is obviously a risk with this sort of project, but I think it's the right thing to do for these patients. And so far it's been good.
And that raises a very good point. Is this whole thing about privacy and it's a big issue certainly here. So in Alberta, a part of Canada that I'm in, it's an integrated healthcare system. So everyone has one unique healthcare number, and all of the lab, whether it's their administrative data or their laboratory data, their pathology data, it's all in one thing. It can all be searched or whatever. So it's very powerful from a of looking at a large database and saying, okay, these are the things we should be looking for. But when you go into EMRs and you're starting to talk to the family doctors, it's really, it's them that need to be looking at the data. We can't look at an individual's data and say, that person over there and who lives over there, we need to go and get them because they're at risk of liver disease. That has to come because that's privacy issues, right? And so they're always coming up against things where, common good, we're trying to do the right thing. But in the end, the privacy of that person's own healthcare data has to be protected, and so and I'm sure Tim deals with that on a daily basis. But it's becoming stricter, and so it's even harder to do these things that are really empowering physicians to actually not just look at data, not look, not have that be asked the question, well, haven't you been looking at my liver test for the last 5 years, and that they've been abnormal for 5 years. Why hasn't something been done? Which I think Tim was just describing, is because everyone's quite happy when someone says, oh, because the first thing it says, well, why wasn't someone doing something about this? Why has this been going on? So there's a frustration at the patient level about why people aren't acting on it, and so we need to create ways that people are empowered to act on it. I think is what Tim is really doing, and everyone's trying to do it. But I think, I mean, many people are trying to do it, but I think that we need people that are very smart, that understand IT and understand the healthcare system, which is the numbers drop quite quickly when you're getting into that sort of group. And then work with people in a way to use the computer techniques that we have to be able to pull that data out and provide it in a way to family doctors that it's easy for them to use to help find these patients at risk for whatever disease, not just liver disease.
I think we're looking at the future. Tim, we're going to definitely have to have you back, have this discussion again at whatever interval you think you're ready. If it's a year from now, maybe. And I want to thank both you and Mark for joining me today, and the Fatty Liver Alliance. And we'll talk to you again soon. Thank you so much.
Thanks for having us.